Very much a big welcome to everybody who took their time. Welcome to the NoTube webinar. Topic is our telemedical approach, and I'll just quickly frame the whole thing, and then we'll get right through it. My name is Aaron Scheer. I'm the current CEO of NoTube. I'm here with my sister, Dr. Lily Beckenbach, who is our medical lead, and we want to give you a little bit of an insight of how we do things at NoTube. We have received some questions and a couple more applications for tonight than are here now, but maybe they'll come or maybe not. That's fine too. We will start with a little bit of a input, just sort of general information so that certain questions might already be covered. And then after that input, we'll just open the floor to your questions, whatever they might be. What I also just want to say is that this will be recorded and also will land on our little YouTube page that is quite cute. And you have already given us your permission that that's all right. If that's a problem, maybe don't be here. It should be fine. Also, you'll only mainly see us who are talking. And last information from my side will be done at 9 p.m. Central Europe time, and we'll have a great time, hopefully. Lily, please.
Hi, thank you very much, Aaron. Yes, so our topic for today is our telemedical approach. And since we do have similar questions, I prepared a few PowerPoint slides, which I would like to share. Then I hope it's easier for you to listen to me. So let's get started here. So I hope, can you see that now? Yeah. Aaron, if there's anything happening, tell me because I can't see only Donna and you now.
Will do.
Fantastic. So, okay. So my goal for the next 5 to 10 minutes is to give you a tiny overview of our telemedical approach. And probably most people would think, how is that possible? How can you do eating therapy with children with severe eating disorders just with this telemedical approach without seeing the child, without touching the child, and so on? And actually, NoTube has been specialized on this telemedical approach, not only since COVID started. We started in 2010 with the same programs we do have now. So we do have a lot of experience already especially with the tube weaning program since already more than 15 years. Just a short overview who we are. We are an outpatient clinic. We are following in a moment only telemedical approach. Our organization is in Graz in Austria. It's founded already in 2010. Medical leader is Professor Margaret Scheer, who also invented this whole program and the Graz model, which I will talk about a little bit later. And of course, we are a multidisciplinary team. So I'm a pediatrician, and we do have physiotherapists, which are also specialized, occupational therapists, and from all different specialities which are needed in the child development. We do have members in the team. What we do, in one sentence, we are very much specialized in treatment of complex eating and feeding disorders, and especially specialized on tube weaning. In general, one can say that the whole therapy program, the tube weaning, but also the other programs we do have, is based on the Graz model, which is also published in literature, and I will say a few words later to that. How does it work? So no matter which feeding disorder or if you're professional, the process is always the same. In the first step is that parents and also professionals can have a free evaluation, which can be booked over our homepage. So this is a free call, free talk with one of our team members for 20 minutes, where you can just ask whatever you want and check out if NoTube can be an option for you and your child. Second step is that we always need to do an assessment, so a medical assessment of your child, which means that we will ask you to upload 3 different videos. We will ask you to upload some medical how do you say it? Reports, sorry. And also we have a very detailed questionnaire depending on the feeding disorder, with a lot of information. And then you get from us if your child is suitable for our program, and if yes, for which program it's suitable. Some cases it's very clear, but in some cases we try to find the best therapy program. And then we do have different programs which last between 3 and 6 months. And on the next slide, we do have our most common ones, our net coaching program. The net coaching is made for all children for tube weaning. So all children who have a tube would go for the net coaching program. Then we do have a program for all the children with, we would say, eating development problems. So yeah, we can talk about that later if this is interesting, but children with no tube, and especially you can see on the picture also young children, we would say 1 to 5. And then we do have a special program which is called Select Me for all picky eaters or children with ARFID. For those of you who know what ARFID means, it's a very wide name for a whole range of different feeding disorders. But it doesn't matter if you don't know as a parent which program is the best for you. We will help you and guide you through, so don't worry about that. So the telemedical treatment, how does that work? This was a very common question you sent us before. I don't know if it's now the same people here sitting, but we do have a secure platform where we communicate with the parents on a daily basis. So you can imagine it's like a Facebook platform. So everyone has a profile, which is of course completely safe, and you can only see your information. And we can communicate on a written base. You can ask whatever you want at which time, whenever you want, and you will get an answer within a few hours from our team members. This is like the base of our communication. Then we do have the possibility, we will ask you to upload videos, and we will analyze videos with you. We have the possibility, and we will ask you to fill in protocols of your child if it has a tube, or also oral intake, also weight and height of your child. And then we do have also information and Zoom meetings, depending which program there is. But this is like the general information which is the same for all the programs. We know that the telemedical approach does have a lot of advantages for the parents, because we know that, especially in tube weaning, we know that it's highly effective. The last 10 years, we compared it to our treatment program in Graz, which was also telemedical approach, but also including a 2 weeks eating school. Maybe one of you heard about that. And we could see that it's from the numbers, it's the same, and it's the same highly effective in tube weaning. This is easier to measure with the tube in the tube weaning process, because if we are successful, that means that a child doesn't need a tube anymore. So it's a very easy and outcome factor which can be compared. With all the other feeding disorders, it's a little bit harder to compare the effectiveness of our therapy. What is the biggest advantage probably for the children and also for you as parents and the whole families is that this treatment can be done within your daily life, in your daily home, and you don't need to go anywhere, and it's not stressful at all. And yeah, it's very easy, and it's made for it has to integrate in your daily life. So we will adapt our program very much to your needs. it's very individualized. This is probably one of the main the biggest or one of the main factors in our therapy. We look very, very much on your child and try to really understand your child and adapt the therapy to really the individual needs of your child. We do have, it's not only me, it's also other pediatricians in the team. So we are very also available in the therapy and everyone. And since this eating therapy there is a lack of professional eating therapy, especially for tube-fed children. So that's why we do have patients from all over the world. And that's why we, since also 15 years, have our therapy in English and German and French. And because we know that's all over the world, there is a lack of speciality for those children. Okay, one of the main, how do you say Säule, Aaron? The main,
Pillar.
no, but that's not the right word.
No,
What I
one of the
was,
main pillars, one of the central pillars of our approach.
thank you, is that our approach is very much child-led. And maybe I just have a few pictures here which make it more clear that we're really, really focused on the child and all what we think, we always try to get the child's perspective, which sounds quite obvious, but our experience also with, we do have also treatments, or we have families who have been treated somewhere else, and we always get the feedback that we do have a different approach of child-led, that the perspective and the focus is much more on the child than they are used to in their normal treatments they had so far. Since that was a very common question, the Graz model is the published base for the tube weaning program, but really it's the base for all our eating therapies. So the left part is now, especially for the tube-fed children, it's a very adapted and supervised reduction of the tube feeds, which means that we need some kind of hunger, since tube-fed children, they have been never ever able, most of them, to feel hunger since they're 100% tube fed after clock and with special times. So this is a factor which is a very important factor in tube weaning process, that we have to adapt the tube feeds on a very regular basis. And this is mainly my job. Then on the second, or on the same time, we need to encourage self-feeding and child's autonomy. This is also very special in our therapy approach. And we need children learn the best while playing. So this is why we need this playful approach, and yeah, need to give the children a chance to explore and have positive experience with food without having the expectancy that they need to eat it. This is always the first stop. And we do see very, very high rates of oral aversion. And this is first step to decrease oral aversion. This was also a very common question.
And Lily, can I maybe just add
Yeah,
one thing?
yeah.
For the child-led, on this slide, please, the child-led in comparison to parent-led. I think that maybe makes it a little more plastic to understand what we mean. We hear that some other programs, we also know that their parents are very distressed when their child is not doing well, of course, and they are certainly distressed that they're not eating, and they become more distressed because we are reducing the tube feed. So we are making what has previously been the one safe thing, we're taking that away slowly because we want to increase the autonomy. And now other programs are very concerned with the parents' desires. Oh, the parents want to feel better, so we should increase the tube feed of the child because then they will feel safer. And this is where we are very much in contrast, because of certainly we care for the parents' well-being, mental well-being. We also support this journey of the change of the child, but our patients are the children. And so if a mother is struggling, for example, in the stage of the reduction of the tube feed, then we need to respect that and deal with that, but we won't act on it regarding the child.
Yeah, maybe it's important to say that we do see many children from all over the world who get a lot of oral therapy with different therapists. But as long as you don't touch the tube feeds, nothing can really happen. It's like learning or trying to learn how to swim and you never feel the water. It's impossible to learn to swim without being in the water. So and this is probably also the lack of help sometimes because you need many people who are specialized because we do have children with a lot of severe medical diagnosis. So we have children with complex heart disease, with genetic disease, and so on. So you really need to be a pediatrician to know how to do a safe tube reduction. And on the same time, you need really psychological and eating development encouragement. Otherwise, it's not a professional tube winning process because there are children which can be led easily, but all the children which are treated by us, obviously it did not work easily, so they need professional help. And then we need really different different parts to make it happen that a child learns to eat. There's one thing where parents I know are very, very concerned is weight loss. And of course, if we do a tube feed reduction, it can lead to weight loss. And this is why this needs to be very, very supervised closely. And many people fear that the children get so hungry and will starve. And this is why I'm putting in we don't want a starving child because a starving child will not be in a position to learn something new. So we need the children in a good condition. So it's not about making the child too hungry. It's exactly the art to find the optimum, the ideal tube feed amount and times and content so that the child is interested. So not too much and not too little. And let's see, yeah, exactly. This is also a very important point is that, of course, if we give less, we need to make sure safety is always the highest priority. So we will train parents to recognize also early signs of dehydration so nothing can happen. Since we do have the tube, we can face those kind of problems very easily and we don't need to fear it if we know what to expect. This is very rare. And yeah, this is kind of our motto, as little as possible, as much as needed during the tube winning process. I think this is my little input overview. I think it was about 10 minutes. And we thought it's the best now to give you the chance to ask whatever is interesting for you. So that's why we keep it short, or I try to keep it short. And I think it's more interesting for you and for us if we discuss your questions and your
Concerns. With that, I will
concerns.
take it and open the floor. Anybody who has a question, please feel free. We prefer if you could ask a question with us also being able to see your face, but it's also not necessary. And thank you for sending in questions, but it's just more interesting in an interaction. So that's why we just prioritize the questions that you can ask us right here, whenever you're
And
ready.
you can use the chat as well.
Sure.
Hi, everyone.
Hi.
Hi.
Okay, I'm all the way in the Caribbean and I got your information because I have been seeking information to help my son, who is now 5 years old. I've been experiencing, well, he has had a eating disorder, I would call it, from the time he started eating. And I have not been able to get the help that I need in the Caribbean. And this is why I have been doing constant research and reading and trying to do stuff on my end. However, I am very happy to be here to get information from you guys. I've read upon you guys. I'm here and on the Zoom call and also getting information and insight from your team. So I deeply appreciate this. I'm happy to be here once more. So my question is, in the Caribbean, my son's pediatrician, because I'm going to keep it short. He has never progressed from eating mashed food. He progressed a little. He eats peanut butter sandwiches and crackers, but he's very specific as to what he eats. So he eats crackers, but it has to be from a specific brand. And he has his cereal, which is soft food again. And I do cook regular food for him, but I need to have it mashed or pureed. So texture is something huge for him. He's quite intelligent and, he communicates with me well. And as he grew, he communicates even better. And he's adamant as to, okay, I don't want to eat it. I am not ready to eat it. And in my research, I also understood that I should not pressure him to eat. And it's different in the Caribbean. If you know anything of the Caribbean, there's a bit of fuss is given when food is administered to a child. And I chose not to go along this path. And essentially, I'm being blamed for it as to my approach. I've allowed him to play with food as well, but I'm getting little to no progress. And he's 5 years old, and I'm willing to get whatever information, whatever insight I could get to get him to want to try. I have also considered ARFID because we would have him to cook with us at home, make pizzas, and he would touch the food, he would engage with the food. But when it comes to having a taste, he will never do this. So I'll be short. So just a nutshell as to what I am experiencing with my 5-year-old son.
Thank you so much for your question, Donna.
Yes.
Firstly, thank you for finding us all the way from the Caribbean.
Yes.
We have, and this is the only part that I will answer, and then I will give it to my doctor sister. We have seen the profile of your child, as distinct and unique as it might be for you and your close surroundings, as normal and everyday it is for us. You describe a picky eating child, and they have their reasons for it and what you can do. We will only now be able to give you super generalized little tidbits, and we'll try. But in order to really sort of help you, we would have to get to know you better, get to know your child, etc. But some tidbits that could maybe make the next eating experience a touch easier might be able to be given. Lily.
Mm-hmm. What you describe is, as Aaron said, a very normal thing. So he's very selective in taste and in texture, as you say. And most children, probably maybe your son as well, need fine blended consistency. Or does he tolerate pieces in his pureed food?
No pieces at all. Has to be smooth. Yeah.
So this is something we know, and I would call it like an eating development delay. He's like stuck in the pureed phase. And this has different reasons, probably. I don't know if he has in other fields also sensory issues, but we would like look very much where is he now and try to find how can we support and optimize things that he can make the next step. And as I said, we need this kind of playful approach. And we know every culture in the world, every culture is special. So we do have sometimes also Asian families. And so we try to find a way which feels good for you and umsetzbar, feasible. But we focus on your son, and we will watch him on the videos, and we will try to find, it's like a different approach. We try to be really noisy and curious. What inhibits him to do things?
And what's the reason? Because often they have a good reason. It's just really tricky to find out.
Yes.
Is his motoric development his motoric development completely normal, or is he also a little bit late in Was he late in walking, or are there things in his motoric development which are a little bit later than usual?
He walked at about 13 months.
Okay, that's normal.
About 13 months. But he does have conversation with me, and he keeps talking about healthy foods and mommy snacks. Snacks are not healthy. Chicken is not healthy. So he keeps telling me this specific thing. So like he's on a healthy
So
journey.
he sounds a very smart boy, so would probably focus on that and try to ask and think. And so for children with this kind of speciality, I would call it, I wouldn't call it a disease, it's just like a delay maybe, or a speciality, but it can of course make a problem in everyday life. For example, if he goes to school and if you're away and you don't have your blender. So this, we try to find out how to make it life easier with this kind of speciality, because maybe he needs more time, and there are some children which still, even if they're grown up, have a special preference for texture or taste. So this is not an illness or a disease, but it shouldn't compromise him in his social life. So we do have a program, especially for children with this kind of, I call it now specialty, which is called the Learn to Eat program, where we have weekly calls with you and work on like small steps to find compromises that he can go, so that he can make like a little step.
Okay, thank you very much.
This would be our approach, very individual with weekly calls. You will also have, we will also look at the whole thing of how is his growth and so on. So we will always look at the whole of your son, and then think together and try out and find out what can we do to push him without over pushing him.
Yes, thank you.
And Donna, just lastly, two things. You as a mother have such a distinct relationship to your child that, you know, everything that happened so far is already informing this thing. And so if we have a Zoom with our physiotherapist, who's an expert on all types of distinct children, and she can have a conversation with him, that will be a different conversation than you are going to be able to have because you are his mother. And then what I would like to propose to you is to just get a free evaluation, like talk to our team, because also what Lily, I thought was interesting, if I might add a question on Donna's, is there are certain things about your child, Donna, that sound like picky eating because he only eats a certain brand of cracker. But then there are other things that sound like a development thing because everything needs to be pureed. Lily, maybe you can say how we distinguish between these two very similar.
Well, we always try to define therapeutic goals with you. So we try to prioritize what would be the most important for you that should change. And what is first, second, and third. And we talk about it. Some parents come and say, we want a completely normal eating child sitting on the table, eating whatever we cook, eating full amounts, eating completely healthy. And then we would say, okay, this is a nice wish, but we know the starting point of your child. We need to make small, realistic steps and goals we can reach. Otherwise, you'll be disappointed because we are not a magician. So we need to talk about what is for you as a mother, and we try to, what do you think, what is he suffering of? Because sometimes we do have the situation that a child doesn't suffer at all, but the mother suffers because it doesn't meet her expectations. So then we talk about it, and we need to look at it from different sides, from a pediatric side, from a social side, from an eating development side. So we will discuss with you as a mother. If possible, we would also talk to your child with you, if he would be ready, if he would be open. This is always the best case, to also get his perspective from him. But in most cases, we work with the parents very intense, and we talk, what is your wish? What is your expectation? What is your goal for the next three months? What do you think is the most important? Because this is very individual.
Yes.
So we have, for example, just maybe before there's another question, I talked today to parents, and they have a 9-year-old which wants to be fed all the time. And he always eats very selective, the same. And then we need to define, is it more important that he eats by himself or he eats different things? Do you know what I mean? We can't reach too many things at the same time. So this is why we have a very intense contact to see, and we exchange our evaluation of the situation, what is realistic. Because if he eats only pureed food and maybe licks on crackers, if you would tell me I want him to eat a schnitzel, we will say, oh, that's really nice, but this will take more time, probably.
Yes.
Maybe if your child has the same wish, then it will happen more likely. But otherwise, we need to make small steps toward a goal, which is a realistic goal. And I think this is one of the main work we have to do, that we really have to
expectation management.
Define
We have to define it, we have to manage it. Yeah. And lastly, the child doesn't have issues. I think we can all empathize. If I would just eat 3 things and I would have a mother who makes those 3 things at any time in exactly the way I want, why would I change my behavior? I understand it's annoying for you, but I'm getting just what I need. And so often these types of kids also come to us more in that age of 10 to 12, because then it's annoying to them. They want to sleep with their friends and they experience shame because they have to bring their puree. And so only then, and this is also partly, the child needs to have something about the situation that he would like to change. That certainly helps. But thank you very much for your question, Donna.
Thank you very much for your responses.
Of course. Our team will post a little link for the free evaluations in the chat. I will come to the next question. Thank you so much. The next question is from Chantal. Would you like me to read your question, Chantal? You can just go like this if you want that. Yes, perfect. Hi, Lily, you're listening. Hi, I'm from South Africa. My daughter has Down syndrome and she has severe oral aversion. She got a G-tube at 2 months old. She's 14 months old now. We have had no improvement in oral aversion or oral feeding. She throws up even after a Nissan operation. Doesn't matter how slow or little I feed her. How can I help her with the aversion? The doctors in South Africa don't have the experience to help us.
Thank you, Chantal. This is like classical case we do face every day. It's a child who is in a perfect age, who has severe side effects of tube, and mostly we have a lot of experience with Down syndrome children. We wouldn't expect that your daughter has any problems, like organic problems with swallowing. I'm not sure if you can hear me because your face is frozen, but I will just go on and you'll tell me if you hear it. So we know that children with Down syndrome, they have a much higher risk for feeding difficulties. You know this as well. And since she's in a perfect age, she has severe side effects. So if there's not a medical reason which is against tube weaning from your doctors, I would definitely, from what I know, recommend that your daughter needs a professional tube weaning trial. And we're happy to support you with that. This is our daily business. We published last year a paper with only Down syndrome children, and we had a success rate even higher than in normal, like almost 100% of the Down syndrome children we were able to wean off their tube. Does this answer your question, or do you have a specific question? More than the answer. Of course, I do not know all the information of your daughter, if she has a heart defect or a hormone problem or whatever.
Lily, maybe one thing you could talk a little bit about timing and tube weaning.
14 months would be the perfect age now. The older she gets, the harder it will be. Not necessarily. Hi, Chantal. If there is a reason to wait, okay, but otherwise, from what you say, if she has a safe swallow, don't wait too long. It doesn't get easier.
Yeah, she does have a heart condition. We are going for a heart cath tomorrow to make sure everything is okay. But she's safe to swallow. She doesn't have aspiration. She just has the severe oral aversion, so that we can't get anything in her mouth.
Yeah. Yes. The oral aversion only decreases with the therapy as I said, playful approach, decreasing her oral aversion and decreasing side effects. If you tell me that she's throwing up very often, this increases oral aversion. I mean, it's clear if you throw up twice, 3 times a day, and if you're always like full to here, it increases your oral aversion. So the oral aversion will only disappear in a professional tubinic trial.
Okay,
This is
thank you.
only
Yeah. She's
with
throwing up 5 or 6 times a day.
Yeah.
So
yeah.
and
So
I
Maybe
feel
you
that's
can adapt
making it
already.
worse.
Yeah,
Yeah.
and I mean, it's this is also something I do see sometimes, that even if the children have an operation, a funduplicatio, a Nissen operation, which was meant normally to make vomiting not possible anymore, we do know that some children, either it doesn't
Close.
hold anymore,
Mm.
it was not a successful operation. This is one option. Or there are children who still are able to vomit even if they have this operation. The good thing about the G-tube, even if they put it very, very early, the good thing is that the weaning process is sometimes even easier with the G-tube than to a nasogastral tube. Since we can use the G-tube in the night, in the sleep, while she doesn't notice it, we can adapt the tube feeds. So for me, I would be very happy if we can support you in this process.
Yep.
Because there is if you prolong and if you keep continuing the enteral nutrition support by the tube, it needs a medical reason for that. And your daughter just needs to learn to eat. I know that sounds easier than it is. But this needs time. Some children, it's very easy and quick. Depending on the oral aversion, we had one child from the Netherlands who vomited already when she saw food. This was the starting point. So a very high oral aversion. She didn't need to touch it. She was always gagging, sitting and gagging. And it just takes longer because her eating development starts. We need to decrease the side effects. We need to decrease the oral aversion and then slowly start and wait for whatever your daughter decides to eat or drink.
Yep. And
transit.
Chantal, if I may add something, I think this is a great example for me to explain our play picnic approach for a second and why this play is so important. Because as one part is that your daughter at 14 months old will not answer our question as to how are you feeling, why are you not eating today, because she's not able to do so yet, but she probably has some reason as to why she's reacting to food in the way she is. We don't know that reason and we won't be able to ask her, but some type of oral trauma when she has been in the hospital a lot and people have
Or the side effects. I mean, if you vomit 6 times a day,
I don't
this
want
is
to
enough reason to have
exactly.
oral
I don't
aversion.
want to risk it. And so what we do in the play picnic, which is something we only do in a physical setting, but it's children playing with each other, and there is a bunch of pudding on the floor, and it's really hard to distinguish, is this now food or toys? And then if one baby touches another baby here, it's a completely different situation for the baby as when the mother comes, and it's certainly simplified, but this is why this playful, it's sort of like the highly sensitive part that is always on the look for to not vomit is just playing, and then slowly this aversion can decrease.
And maybe
I let her
Chantal,
play with food.
Yeah.
So she loves playing with the food. She just doesn't
Good start.
put it in her
most
mouth. She
cases,
doesn't.
Chantal, if they vomit so hard and it's not cow milk protein allergy or whatever, it's the volume too high, that the toleration is not good enough. So either maybe you can change the content or the volume. In most cases, the volume is the problem.
Yeah,
So
no, I
it's
think
too
it's
much
the
volume
volume
to handle.
because we've changed everything. She's gluten free. She's milk free.
Yeah.
So
Okay. So it's the volume, and if she's not underweight, and you know that there are specific Down syndrome percentiles.
yeah,
So if she's in a good range,
she's on the 5th percentile.
okay, then please reduce the feeds.
Yeah.
Okay.
That will reduce the vomiting.
Thank you.
You're very welcome.
You're welcome.
Chantal, seek some professional support. I think it's a wonderful advice to reduce a little bit to just get the vomiting down. But Lily, you can say this, but eventually it becomes a medical intervention, and one, right, just needs to be responsible about that.
Thank you.
Good. You're very welcome. Thank you very much for your question, Chantal. And the link for the free evaluation is also in the chat. I think, Donna, your first question
Yes.
is really about that, Donna, as far as I
Well,
understand.
not well.
Could be. Donna, how did you
could
mean
be.
your question? You're very able to talk, I know.
Well, I was wondering maybe in that case, if that's another contributing factor, is there something in the formula or the
Yes.
food that is an allergy and might need to be changed?
Yeah. Yeah, now for the case for Chantal's daughter. Yeah, okay. Normally, in general, speaking, of course, there are some allergies which need to be excluded or tested, but it's very rare that children develop a feeding disorder due to an allergy, I would say. But of course, if the food toleration is so bad, one has to really think. And as Chantal said already, they have no milk and no gluten. So it's mostly the volume and also the content of the formula, the industrial formula. Like if you have a formula which is 1.5 calories per meal, it's very hard to digest. So I do know families who change to self-cooked, self-blended food, which is normally tolerated much better.
Perfect. Donna, you have a further question because I saw you had one on the form coming into today, please.
I don't remember which one that was, but I'll go with I wonder if you could describe an intervention, a telemedical intervention. I watched some of the videos where you do the play picnic and that looks like so much fun. How does that translate to a televisit? And especially with I'm in Alaska and a lot of our families are challenged financially to play with food. How do you balance that?
I saw your question, Donna, and I can add something, Lily. How do you make food playful without being able to waste it?
That's a hard question. But I will start with the other one. How can you do a play picnic at home if you just have one child and not you don't get the same environment as in the eating school where you have 10 children? We always find a way because it's not about the children don't need 10 children on the floor and not every child needs to smash and throw with food. So we look very closely to where does the child stand in the oral development, and we try to find, and a play picnic can also look like a child sits in a high chair and gets two things and just be able to like mash a little bit around. It doesn't need to look like on the video. So we try to find, depending on the child, on the age, on the development, we sometimes ask the parents, do you have a friend with a child in the same age? Maybe you can have a little tea party in the afternoon and have a little play picnic together and find something. Sometimes it's also about if a child can already walk, have you got a play kitchen, buy a play kitchen or get a drawer in your kitchen which your child can reach himself and put some snacks in it. So it can look very different, and the children don't need too many people. They just need an atmosphere where they can feel safe to do something and make positive experience with the child. So sometimes I do recommend put the child in the bath, in an empty bath, and give him some, and then he can smear and do things. And then afterwards you do a shower, and then it's not a huge mess. And we don't want parents to clean up 1 hour after this mess and the child doesn't learn anything from it. So we have to make it feasible at home, and the focus is the child needs to make positive experience without having to eat. This is like the main sense of the play picnic. And how we get there are 1,000 different ways of how to do this in the atmosphere or in the environment of the child. And what helps a very lot is, but this we never know, is that if the child has siblings, for example, we do have many twins who have one twin is eating, one twin is still on the tube, situations like that. And this is, of course, very helpful. Every sibling who is a normal eating child is like a
role model,
like another therapist in feeding therapy.
Lily, could I just ask, could you also play with non-edible things and achieve a similar result?
No.
Okay. So there has to be
We try
this
to give the
boundary.
children things to play which are eatable, although we know that they don't eat it. So I recommend, because this was the question, how can we do this without wasting too much food? We try to focus. Sometimes it's enough to have 3 marshmallows to make a little tower, or put them on a stick, or make so the child normally doesn't need 15 or 20 different things. We try to focus on what is age appropriate for the motoric of the child. And maybe it's just a Haribo string and they make a little, I don't know, bracelet with it. So we don't need thousands of things. We
And
just
they
need
can
the
be
child
homemade as well.
It can be homemade. So I think I don't, or it doesn't, is not my, I don't have the feeling that parents which are under treatment, they like throw away. Yes, of course, sometimes you prepare pureed food or you prepare a bottle and which is not drink, is the child doesn't drink. But yeah, so I wouldn't say we do excessive food waste, but of course there will be food which is not eaten.
Yeah. And Lily, I think this is from a backdrop of an already very financially tense and food scarce situation. Donna, I think maybe an intervention could be to explain to these parents that as much as this is food for them, and this is what they need to cherish because they need to feed, this is for their child training material. And
Okay.
it sort of, it becomes a slightly
The
different,
different attitude, and it
it
makes
doesn't
a
help
different.
the
Yeah, it
issue.
makes a difference if a child plays with cars or he plays with things which smell
Yeah.
or melt in the hand with chocolate or something. It makes a difference. So children who are very oral aversive or have a big aversion towards food, this is the only way to get children to food,
And then
in
Donna,
our opinion.
I remember from our last conversation, and this I think is just an interesting part I want to highlight to other parents as well. Lily, when these parents aren't particularly food euphoric themselves, maybe those parents don't, I remember you telling me maybe they drink Red Bulls and something that is just as easy to fill it up as possible in this scarce environment. Does this affect children when they see that? Yeah.
It does affect my children also are affected by our eating behavior at home. And
Yeah.
if you're a very sporty family and if you use every free minute to go on a hiking tour or a cycling tour or whatever, the chances that your child will also be more active is higher. But it's not necessarily, but we try to give the children a kind of feeding world. We try to make them hungry and we make them a lot of possibilities. So we will give them also unhealthy food. We will give also a 1-year-old an ice cream. If he can hold it and if he has fun and licks it, I would say, oh yes, okay, we reached the goal that the child does get in contact with food. So I have to prioritize my goal. And yes, I'm also not happy to throw anything in the bin, but if it helps my child to learn to eat, I would say, okay, this is worth a few euros more that I mean, most things you can also buy cheap. Most things are not extremely expensive.
Lily,
We
Alaska
Alaska,
is different than we're used
Alaska
to.
is different. Okay.
Donna, did we answer some of the question?
Yes, and I really like the idea of the bathtub. Like I should have thought of that too, because the same family is also a clean freak. So gets very upset if there are crumbs on the floor, if there's a mess, but the bathtub might be a place that might work.
Very good. Always a reason to try. I wanted to open the floor sort of one last time. I know we have 2 participants that I see beautiful Hebrew lettering and I see the word iPhone, but I don't know what it is that maybe you brought a question as well. Also feel free to use the chat. I just want to make sure that if you brought a question, you were able to ask it. And don't feel pressured. That's not what we want to do around here. Otherwise, I think, Lily, what is your idea? Should we finish a little early? Maybe Donna, you have another question. Do you have another question, Donna? No? Great. Well, then, Lily, do you have anything, an
can close.
impulse that you wanted to know?
No, we're happy
We're
to help
happy
and get
to
to
go to
know
bed
you
as well.
and the speciality of your child.
Exactly. Wonderful. Thank you, Donna. Thank you also, Donna, the other Donna, and thank you, Chantal, for your questions. Please, anybody contact us if you have questions, also email us. And thank you very much for attending. We hope to see you soon. Bye.